Our next speaker is Professor Kath Checkland, my colleague here at the University of Manchester, who's Professor of Health Policy and Primary Care. And Kath's also one of the directors of the commissioning PRU, PRUCOM, as it's called, that's for short. And she's going to be talking to us about the Health and Care Bill and really the implications for research and service commissioning. And basically our hope is going to help us understand how to influence commissioners, but maybe that's a bit naughty to ask you to do that.
Thanks, Chris, and thanks everybody. I'm going to make two declarations of interest at the beginning of this. So the first is that I'm also, as well as being Professor of Health Policy and Primary Care and a researcher of commissioning, I'm also a GP. So my day job for many years has been as a GP, but also I have a really important declaration of interest, which is that I spent Sunday night into the early hours of Monday morning in the A&E department of Chesterfield Royal Hospital with my frail 91-year-old father with dementia, and so I think that the work you do is so important, and it's great to be here to talk to you. So Chris and I, originally when he asked me to speak today, he said, oh, maybe you can talk to us about how we might influence commissioners, or how we might get things from, as we've heard just now, there's evidence, and then there's services, and the sort of link. How do you get what you need, the evidence, into how you provide the service? And of course that's what commissioning is, and commissioning is most importantly about planning and resource allocation, because obviously if you're going to put more into one service, if you haven't got any more money, you've got to move money from one service to another. So commissioning is the process by which those decisions are made. And the problem is, we're talking about at the moment, how do you do commissioning, or how do we influence commissioners, or how do we work with the commissioning system? The answer is we don't know, because the commissioning system is in the process of being thrown up in the air due to the Health and Care Bill. And in talking to many colleagues around the university and colleagues in the NHS, it's become clear to me that not many people really understand what's going on with the Health and Care Bill. And so Chris and I felt that it would be useful for me to run through what's in the bill, what it means, so that we can start conversations about who you might need to talk to in your particular area if you want to influence decision making about resource allocation and services. Spoiler alert, we don't know, but I think it's important to at least set out what the uncertainties are and when they might potentially be resolved. So the Health and Care Bill timeline. NHS Long-Term Plan 2019, there was an appendix at the back from NHS England suggesting legislative changes that NHS England felt were needed. That was followed up in December 2020 with a longer document which set out what they wanted to happen. And the DHSC responded in February 2021 with a white paper which set out proposed legislative changes, which weren't exactly what NHS England had asked for. In particular, they included a stronger role for the Secretary of State than had been asked for by NHS England. 2021, the bill was introduced. September 2021, there was some guidance, not very detailed, published. And ICSs were supposed to go live in April 2022. That's been put off to July 2022. And if I'm absolutely honest, I wouldn't be surprised if it was further put off, but we'll see. They might move things through quickly. So what are ICSs and what are they intended to achieve? So from the guidance, they are partnerships of health and care organisations to come together to do the commissioning, plan and deliver joined up services and improve the lives of people who live and work in their area. And they're given these four aims. So improve outcomes, tackle inequalities, enhance productivity, which is an interesting one, and even more interesting, help the NHS support broader social and economic development. So not many asks, really. And very strong claims are made. So the claim is made that collaborating as ICSs will help health and care organisations tackle challenges, including all of these things. So supporting people to stay well, acting sooner to help prevention. And I think, if I'm absolutely honest, coming back to the presentation from NICE, the evidence that ICSs will deliver all of these things is pretty thin. I've just finished a research project which was looking at integrated care, and I've been involved in some reviews of the literature, and the link between structural changes, which is what the integrated care system reform is, and these sorts of outcomes is limited, really, to say the least. There's lots of reasons to suppose that supporting and enabling collaboration between organisations might help these things, but we don't have any evidence that that's actually the case. So what are integrated care systems? They include two main things. So the first is the statutory body, which is the Integrated Care Board. And this essentially is lift and shift from CCGs. So the Integrated Care Board will take on all the statutory responsibilities that were previously sat with clinical commissioning groups, also their staff and also their assets. There will also be an Integrated Care Partnership, which is a partnership board, which basically brings together local authorities in a local area and the local NHS. And I'm going to talk a little bit more about what the responsibilities are of those two bodies, the board and the partnership. The ICB will have an independent chair, and that means someone who's not employed in any local organisations. And there will be two non-executive members. And that's not actually very many when you think about the number of non-execs there are on hospital trusts, for example. There will then be executives, so there'll be a CEO, a chief finance officer, a medical director and a director of nursing. And then there will also be local provider representatives and local authority representatives. So there'll be one from a local trust, one from primary care and one from a local authority. Which local authority is up for debate, which primary care person, which local trust, all of those things are up for debate locally. The statutory roles and responsibilities. So the Integrated Care Partnership only has one, and that is to develop an integrated care strategy which will respond to the requirements of the local joint strategic needs assessment. And JSNAs have been around a very long time and they will continue, and it's the Integrated Care Partnership is supposed to produce a strategy to meet the requirements. The Integrated Care Board will then plan to meet local care needs in a way which has regard to the ICP strategy. So that's not very strong. So the Integrated Care Partnership doesn't really have many levers other than to complain to NHS England if they feel that the Integrated Care Board is not having regard to its strategy. They will do all the classic things around commissioning. They'll allocate resources, establish joint working and relationships, establish governance arrangements to support collective accountability, arrange for the delivery of services, do population health management using big data. They'll take delegated responsibility for commissioning primary care, and I'll talk a little bit more about that in a minute. And then all of the kind of ancillary stuff around estates, workforce planning, and this contribution to economic development, although we don't quite know what that means or what it'll look like. So how are they going to do this? So ICBs are lift and shift in that they will take on all CCG functions, but the guidance makes it very clear that they don't just want ICBs to behave like CCGs, and they are being given new flexibilities. So they can deliver commissioning activities differently. So there's some technical changes, which means that they can do more delegation, or they can work jointly with other authorities. They can work jointly with local authority. I mean, they always could, but there's a technical change about something called double delegation, which makes it easier for them to exercise their responsibilities collaboratively with other organisations. But how are they actually going to do it? So I just thought I'd give you a reminder about what is commissioning. And as I said a bit at the beginning, commissioning means the assessment of needs and the arrangement of services to meet those needs. So if you think that you need a new frailty service, if you think that your local hospital needs to establish an acute frailty unit, you've got to persuade somebody to pay for that. Historically, the ideological position embodied in in 2012, the Health and Social Care Act, there was an ideological position embodied in that act, which was that competition between providers was the best way to ensure that services met needs, and the position was that would drive up quality and hold down costs. We've now shifted, and the new ideology is that collaboration will be more efficient and will drive all of those benefits that we saw earlier. And I have to say, for me, that's a welcome change. I think that if you've ever worked in the NHS, I think collaboration is in our DNA. And I think if we can make it work, definitely it has a better chance of delivering joined up services. But over what geographical scale should commissioning happen? Should commissioning happen? And this is something that we've thought about a lot because we research commissioning. And the answer is always, it depends. And what the evidence suggests is that if you're dealing with complex, rare and specialised services, you need to commission those over very large geographical scales. So that's the ICS size. So just in case you're not aware, there's going to be 42 ICSs across England, and they cover populations between 1 million and 3 million. So they're big. And that's the footprint over which usually it makes sense to think about complex, rare and specialised services. Historically, routine community and secondary care services, so your bog standard community nursing services in the community, hip replacements, services for frailty, cardiology, routine, local secondary care and primary care, secondary care services and community services has always been done across a population which we're currently calling place. And what that means is basically the historical footprints of what used to be local health authorities, then health authorities, primary care trusts, CCGs. They all operated on this footprint of round about 300,000-ish. So for example, in Manchester, we had Stockport CCG, we had Bury, we had Bolton, etc. And there's always been, so secondary care services, evidence suggests that this routine community and secondary care services need to be commissioned on that kind of footprint. Primary care needs to be local. So you need strong relationships between commissioners and a population of small-scale providers. The commissioners need to know their provider population, they need to know their strengths and weaknesses, and they need to be there to support them to ensure continuity of service supply. So who's going to be doing commissioning under the Act that's going through Parliament at the moment? Could be anybody. So the ICB could be the commissioning body, could commission all of those things that I've talked to, or it could delegate it to a committee, or it could delegate it to something at place level, which they're calling a place-based partnership, or they could delegate it to a provider acting as a lead provider for a group of providers, or they could delegate it to a provider collaborative, which is a large-scale collaboration between providers which may cross ICS boundaries. So it really is almost anything. And all of this has got to be set out in a function and decisions map. And I first wrote this slide in September last year. And when the guidance came out and it said that every ICS must produce a functions and decisions map, which sets out exactly who and where these commissioning responsibilities are going to be delegated to. I've not seen one yet. I've been searching for them. They're not available publicly. I'm hoping that every ICS has got one and they're working on them internally. But at the moment, we don't know in any particular area. It's not publicly available knowledge where these kind of functions and decisions are going to be delegated. At place level, there is going to be a place-based leader who's going to have responsibility for simplifying, modernising and joining up health and care. So not a big ask. And systems are being told they should delegate appropriate resources, autonomy and decision-making capabilities. But it doesn't say what those are. So we know there's going to be something at place, but we have no idea what it's going to be. And it may be different in every different area. And that's something that I'll come back to at the end, because of course, if what happens in, say, Manchester is different from what happens in Derbyshire, where I work, and is different from what happens in Birmingham, then obviously, as people trying to influence commissioning decisions to get evidence into practice, that's something we're going to have to be cognizant of and to try and get our heads around. So what is place? And again, we've kind of gone back to basics. There's guidance about how to identify place. And it's got to take account of local authority boundaries, doesn't specify whether that's single tier or two tier, how local people use services, how community services are organised, and geographical features. Now, of course, that isn't necessarily actually very straightforward. So again, using Derbyshire, where I work as an example, how local people use services. If you're in the northeast corner of Derbyshire, as I am, half my patients go to Sheffield, which is in a different ICS. Half my patients go to Chesterfield. Much of it depends on where they live because of those geographical features, which are obviously bus routes, etc. And there's hills in the way, and there's a tunnel and trains and all those kinds of things. If you live where I do, it's actually quite hard to get to Chesterfield. But community services are organised on a geographical footprint within Derbyshire. They don't go over into Sheffield. So you can already see that there are complications at boundaries. And of course, we've had place-based entities, as I said, going way back. We've had PCTs, we've had local health authorities, we've had health authorities. So it is interesting to me that we're pretending place is new, and we're redefining it, which does seem to me to be a bit odd. What will places do? Well, frankly, we don't know. There's lots of things they might do, service delivery and transformation, for example, but they will only do these things to the extent that they are delegated by the ICB. And we don't know, until we see functions and decision maps, we don't know what's going to be delegated by which ICB to which level. Just a very little bit about provider collaboratives. Provider collaboratives are really interesting because they're not statutory. They are not in the bill. There is nothing in the bill about provider collaboratives. But NHS England have made them a prominent feature of their guidance. And the idea is that every provider in the country will join a collaborative, and some of these will be very big. They'll cross ICS boundaries and they will work together. And I think there's a real potential for a clash between the needs and priorities and objectives of provider collaboratives and local place-based needs priorities of the place-based partnership. And the guidance says we expect provider collaboratives to agree specific objectives with one or more ICS. And they have to be consistent with the wider system, including place-based partnerships. But of course, it really isn't axiomatic that the objectives and priorities of large-scale acute providers will be the same as those working in a local place trying to improve care in the community, for example, or looking at primary care. And so I think there's a real potential tension between what goes on with provider collaboratives and commissioning and how it's delegated and what happens at place level. Finance, I'm not going to go into finance in great depth. There's going to be a move away from PBR to a blended payment model, and an ICS has got to agree how financial risk will be managed. But of course, that in itself is potentially problematic. I have a dear friend, Pauline Allen, who's a professor in London, who has done a lot of work on this, and she always says, follow the money. Who's getting the money and how are those decisions being made? And of course, early research we've done on the development of ICSs has shown that it's these financial decisions and financial risk where the potential for disagreement and clashes, frankly, clashes of priorities can happen, because you've got to, if you're going to make a decision about who's going to pay the cost of, for example, shifting money from a large acute provider into the community, that's a financial risk to one organisation, and how that's going to be done will really matter. So what are the implications of all this? The timescale is really tight. The bill is still in the House of Lords at the moment, with amendments still being considered. And one of those amendments actually was put down by one of the House of Lords. We've been talking to them about this. We've been talking to civil servants about this, because we feel, as you can probably tell from what I've been saying, that responsibilities at place level should be put on a statutory footing. We think it should be specified what should be commissioned at place level, and that should be enshrined in the bill. And have been some amendments put down to say that, but I would be very surprised if they were passed. The current guidance is permissive and vague, and at times contradictory, because there's a kind of assumption built into it that all of these conflicting priorities and objectives can be easily resolved. And there are issues that are still not clear. So the big one is who's responsible for what, and who's accountable to whom for what. And the answer to that is we don't know. We know that the ICS will be accountable because it will be the statutory body, but until we know what it's going to delegate to which bodies, we don't know who's accountable for spending decisions, resource allocation, etc. And obviously very much depends upon collaborative relationships, because that's the only way that you can reconcile different interests. And I'm particularly concerned about what if the needs of place clash with those of a provider collaborative. And that's one of the reasons why we feel that commissioning at place should be put on a statutory footing, so that place has a statutory responsibility which can override what a provider collaborative might want if necessary. A sort of broader point is that there's always been a separation between planning and resource allocation and provision. Right back, although the internal market only came in the 1990s, prior to that, there was always a separate planning authority. And now we don't have that. We have large-scale providers involved in the decisions about resource allocation. And that's a first. We've never had that before in the NHS. And that's interesting because that could be potentially quite profound. And ICSs are very, very large. So historically, detailed service planning and delivery has always rested at place level, not at the level of ICSs. The other thing, of course, is that because everything depends on these collaborative relationships and these decisions about what gets delegated to whom, it will privilege those areas that already work well together. And there's a danger that areas which struggle where those collaborative relationships have not historically been established will fall further behind, and that's a concern. In terms of research and dissemination, I mean, there are potential benefits, and I'm not against these reforms. I just think, to be frank, they're being not very well, not particularly well implemented, with far too much left up for grabs. I think that the very basics of who's accountable to what, who's accountable to whom for what, should be established in statute. It shouldn't be left up for grabs. So at present it's unclear who's got responsibility for what, but these functions and decision maps are going to be key. And I think that one of the things that Chris has asked me about is how do you go about getting change in your local area? Well, get hold of your function and decisions map, because you need to find out who's responsible for what. It's possible that implementation of evidence could be streamlined across an ICS, but again, that depends on how functions and responsibilities are distributed. And it's possible that there could be a real advantage for research practice if permissions and engagement could be streamlined at ICS level. So that's it. I've gone very marginally over my time, so I'm sorry about that, Chris, but it's a whistle-stop tour around a very complicated piece of legislation. And just to say one final thing, it's not about privatisation, honestly, please, it's not.
Thanks so much for that, Kath. And I didn't think you'd gone over your time. I thought you were dead on. Thank you. So I haven't been able to follow the chat while listening to you. Let me just see if I can see who's asking. Yeah. I can't see any questions in the chat.
Somebody's carrying me to task just to say I shouldn't talk about bugs. You're absolutely
right. Saw the bog standard comment.
I don't mean bugs. What I mean is the bread and butter day-to-day services which make the NHS run. The things like me sitting in the A&E department with my dad. They're the absolute bread and butter that keeps the NHS on track.
We're human beings, and we say it as we see it. We use ordinary language from time to time. So yeah. Any questions, please, from the floor? Where are these function and decision maps then? Where are?
Well, I think that
whose door should we knock on in Greater Manchester?
Good question. The ICS, the designated ICS leader, I guess.
Yeah.
There must be being discussed, because they have to, if they're going to be up and running by July, they need to know who's responsible for commissioning what, who's going to be making resource allocation decisions. So I'm hoping that they've got working drafts of these function decisions maps, but I've been Googling and I can't see any. There's none appearing in any in any minutes that I can see. So I suspect they're internal, and I can see why people are keeping them internal, because if you're making a decision about what the responsibilities of a local place level are, you might not want that to be discussed until you've thrashed it out internally. So yeah, I mean, I know we've got some DHSC people on the course. I'd be really interested to hear from them. And yes, Rachel's got her hand up.
Hi, Kath. Thank you. Kath, I wondered if you've got anything to say about ICS's duty with respect to fostering research and innovation, because clearly that's something that really matters to ARCs and AHSNs. And I just wonder if you've got a view on that.
I definitely do. Yes, I've been having a few conversations with a few people about that. I think fostering and making it easier. I think because I think the big thing for me on that is permissions, and I think there is a real opportunity for ICSs to say, actually, because we're all working together, we're collaborative now, we're actually going to have a single decision making point for research, particularly interventional research, to make it easier. And I think that is something that ICSs could do. And I know that the HRA are interested in talking to ICSs about that and about how you might streamline permissions. And I think that's such an important role of ICSs. So I think it's a potential benefit. It's a real potential benefit, and if you can get a single R&D function at ICS level that's job is to facilitate rather than prevent research, but that requires individual trusts to cede their responsibility for gatekeeping research, and that's going to be interesting to see whether they can do that. Helen's got a hand up.
I've got Helen, then Jane, then Mike. Cool.
Hi, I just wanted to ask thank you, really good overview, that was great. But do you think that our Manchester context will be any different because of our devolved budgets? So it's just...
I'm so glad you've asked that question, because it allows me to mount my hobby horse. Manchester doesn't have any devolved budgets. Manchester has never had a devolved health and social care budget. Budgets in Manchester have flowed in exactly the same way as everywhere else. The only difference in Manchester was that every area had access to what was called sustainability and transformation funding, which was basically funding to bail out trusts that were failing or to support innovation. And the only difference between Manchester and the rest of the country was that Manchester was allowed to give out its own sustainability and transformation funding rather than NHS England giving it out. All other budgets in Greater Manchester sat and flowed exactly the same as everywhere else. So the only difference, I think Manchester does have an advantage, and I think the advantage Manchester's got is that it's been developing these collaborative relationships for some considerable time. However, the ICS is very different than Greater Manchester devolution, particularly the fact that the default before was that CCGs were sovereign because they were statutory bodies, and they ceded some of that to the partnership, and they worked together by ceding things to the partnership. The Act turns that on its head, that that places have nothing unless they're given it have no statutory authority or no role unless they're given it by the ICS. And so it's turned that relationship on the head. So I think from that perspective, Manchester, I mean, they've definitely got those relationships, but the whole thing has turned on its head compared with the initial devolution.
Michael Clark.
Thank you, Chris. Thanks for that, Kath. That was, I guess, really illuminating in just seeing how foggy it all is. So thank you for that. I'm from LSE and the NIHR School for Social Care Research, so you know where I'm coming from. And I'm just wondering, do you have any thoughts on where this leaves local authorities and the adult social care functions and in relation to integration with healthcare services?
Really interesting question and a very good one. And the answer is, I don't know, and I'm not sure anybody knows, because so much depends on the functions and decisions maps. And there's a lot of sort of murkiness around, because obviously the ICSs are huge, so they cover more than one local authority area. And so there's lots of things about who's going to be represented, you know, which local authority is represented on the board. The others will be represented in the partnership, but as I think I've tried to illustrate, the partnership is pretty toothless. All it does is produce a strategy, and so much depends on what's devolved to what. And how those relationships work, because of course a lot of local, say in Manchester, again to use that as an example, we've got the boroughs, we've got Bury, and we've got historically very good relationships between the local authorities and the CCGs at borough level, and it would be a shame if those relationships were trampled all over, but so much depends on what roles and authority is ceded to the right level. And so it's about what arguments are being made internally about that. I mean, I think in terms of the practicalities of collaboration, it should be easier, although actually that, to be really nerdy about it, the statutory mechanisms by which collaboration happens, section 75 of the NHS Act 2006, remains. So, you know, the kind of statutory mechanism for collaboration and sharing budgets remains the same. And you might hope that removing competition between providers and encouraging collaboration might support collaboration, better collaboration with social care. And clearly around frailty and ageing and all of those things, we need it desperately. But until we've seen the functions of decision maps, until we know who's responsible for what, it's really difficult to know how it's going to work in practice. So I think I know the Local Government Association has said quite a lot about the bill, and they've put in quite a lot of, they've done a lot of briefings and what have you. And I think they were quite disappointed about the kind of the lack of kind of recognition of the local authority role in the legislation, I think. I mean, have you got any insights beyond that?
No. I think, as you say, I think a lot will have to just be played out locally, and we'll see what happens. And of course, potentially there's some area of contrast in that adult social care is still very much organised on the basis of local markets, employing a commitment to competition. So we'll see if people wanted to commission some kind of joint service across health and social care, and health was pushing more for a collaborative approach, what would social care's position be? So I think there's lots of tensions and kind of micro politics, as you say, to still be played out. Yeah,
and you know, the sort of, because they have the best value thing, don't they, that they have to go with best value, and that makes it very difficult. And I think it's possible to fudge things. So I think, you know, a lot of the work around care homes that's gone on during the pandemic has kind of fudged those things. But once you start talking about, and this is that my dear colleague Pauline always says, follow the money. When you start giving money to things, then that's when it starts to become difficult and contentious. And that's where in our early research, so Pauline's been following ICSs as they develop, and the thing that she's found is that there's a real tendency to push difficult decisions into the long grass, because of course difficult decisions threaten collaborative relationships, and if you're having to decide to give money to one thing and not something else, that's where you start to get difficulties. Or when there's financial risk got to be allocated, that's where things get difficult. And so there's a lot of hope invested in this, that collaboration will solve all these problems.
In the absence of seeing other people screaming, I'm going to ask, how do you think prevention will come out of all this in public health?
Public health is interesting. Public health is interesting because so public health remains with local authorities. Public health has, but there is within the Act, there is there is something, and I can't remember exactly what the clause says now, but there's something about that they basically reserve the right for the NHS to do some public health functions. And there's quite a lot in the guidance, particularly around the notion of population health management. And, you know, so where does population health management and public health and prevention, where do those things all fit together? Because actually, I think population health management, that whole idea of big data, finding out about your population, tailoring services to the needs of the population, kind of talks at odds to the traditional public health model of, you know, social solidarity and you know, kind of community assets and supporting and prevention in its widest sense of social of determinants of health. And so I think there's a lot to play for in public health. I think
I probably ought to stop there, much as I'd love this discussion to go on. I think it's incredibly interesting. And maybe you give your talk again at the end and we could possibly then understand what's going to happen.